Josh?
Yeah, no, I have read it in detail before and made notes, but so I skimmed my notes and.
Oh, good on you. Good on.
So
that's the best way to do it. So the topics today: neurophysiology and the neurological exam. Does anyone have any strong preferences, or does anyone want to discuss anything specific? No.
No.
So I think the reason I wanted to cover neurophysiology is because it's a chapter in Edinger and we're working our way through Edinger, so that made sense. But I think it follows on really nicely from all of the cardiac physiology that we did. So action potential generation and how sort of the electrical signals move through the cells. So I just want to revisit that quickly because it's really easy and simple. So do you guys remember at rest when we've got a cell that is capable of generating an action potential, so muscle or nerve? Can you remember at rest, where's the sodium, outside or inside?
Outside.
Outside, great. Where's the potassium?
In.
Great. And what maintains that?
Pumps, isn't it? I think. So potassium pumps.
Absolutely. Yeah. So is that a passive process or an active process?
Active.
And what does that mean?
You're just using ATP to have the channels pumping.
Absolutely. So the two things that are required for that are functional pumps and energy. So if there's any reason for any cell to have energy deficiency, so hypoglycemia, for example. Morning, Jeff.
Good morning.
Yeah, so hypoglycemia, hypoperfusion, so if they're not getting blood flow, lots of different reasons why ATP levels might go down, or that those pumps might be dysfunctional. Can anybody think of any toxins that might impact those pumps? I can't. Sorry, I've got that wrong. Ignore me. Sorry, as we were. So the reason for the pumping and maintaining the sodium high outside of the cell and the potassium high inside of the cell is to maintain a gradient between the outside and the inside. So do you know what the gradient means? An electrical gradient?
Membrane potential that kind of opens the sodium channels. Is it
yeah, it means that you can trigger a response in that cell by opening a channel, and that the ions are really going to flood through. Exactly. So the bigger the gradient between outside and inside, the faster a change you can make in the state of that cell, because the sodium is going to move in a lot faster if there's a big potential difference. So cells that need to react really quickly, obviously cardiac cells, muscles and nerves pretty much exclusively. So dealing with nerves specifically, do you guys remember, so an action potential is triggered, what ion moves first? What channels open first?
Potassium, isn't it?
First, actually sodium, because that's the one that's going to flood in really quickly and change the interior of the cell from negative to positive. So if you think about, remember those, I'm going to draw for you.
Awesome.
Okay, so remember these graphs. I don't know why that's red. So if we fit 0 here, and we sit minus 65 and plus 65 up here. So the cell normally sits at minus 65, and that negativity inside the cell is maintained by the negative ions and also by proteins, which carry a negative charge inside the cell. And obviously there's a lot of protein inside the cell. So we've got, just coasting along, and then something, so in the case of a nerve, a neurotransmitter usually will trigger an action potential. So we get opening of sodium ions and flooding of sodium into the cell really quickly. And then we get to positive 65, where sodium's now at equilibrium. It's stopped flowing. And then we get our, which channels open next? You're on mute, Josh. So.
I think potassium starts pumping out of the cell.
Is it pumping or is it flowing?
Flowing, sorry, flowing. Yes.
Flowing,
Yes,
exactly. It is a passive process.
Passive.
What's driving the potassium out of the cells now?
The gradient. It's going down the gradient.
Exactly. So the potassium concentration gradient is very high. So the change between inside and outside. So the potassium wants to go out. But also the electrical gradient. So potassium's a positive ion. It's going to want to balance out that electrical gradient. So the flow of potassium is going to bring the potential actually right down to below that resting potential. What's this period called?
Refractory period, is it?
Yes. Thank you, Jeff. Excellent. What does that mean?
You can't generate one?
Yeah, exactly. And why is that? Where is your potassium at the end of this process? So at this point here.
Oh yeah, it's all outside of the cell.
Yes. Well,
back in first.
Exactly right. So we've got to get those sodium potassium pumps going to correct things.
All right.
So then we're going to switch the sodium and potassium back to the opposite sides, and then we're ready to go again. So we get back to this point once they've all switched back. But to maintain it at this point, so sitting flat and ready to go, those sodium potassium pumps have to be working. Good.
So there's no calcium channels involved there. You've not mentioned calcium as you do with cardiac muscle.
Very good point. So what was the role of the calcium channels in the cardiac muscle action potential?
It lengthened the downward phase of the curve. It sort of flattened it to a degree.
It gave us a little plateau, didn't it? So that's what the cardiac one looked like.
It sustained the contraction.
Good. Because just a little flutter isn't going to do the job in a heart. We need it to really squeeze. So the way that the heart does that is via calcium channels, which open and maintain that positivity up the top here. And then our potassium channels open here, a little bit slower in the heart. So nerves, they want to conduct this signal really fast. So we will talk about calcium channels, but they don't work at the proximal end of the nerve, at the cell body, to generate action potential. They're not really involved in the transmission of action potential down the axon, but right down the other end of the nerve, they are very involved. So I'm going to get rid of this drawing. Oh, I'm just going to stop sharing. Excellent. So the things that are controlling whether an action potential goes or not is whether we've got that potential difference, electrical and concentration gradients. They have to be intact, but also which channels are open, so how permeable the membranes are to the channels. So the channels are pretty much closed all the time until you get a signal from a neurotransmitter, in the case of nerves, which causes the opening of those sodium channels and triggers the action potential. So there has to be a trigger, otherwise things would just be firing off all the time. So examples of where we have problems or where the clinical relevance of these channels are. So say you had a dysfunction of your potassium channels. What would happen?
Well, is the dysfunction that they're not working at all, or is that they're constantly open?
Really good point. So there's decreased decreased permeability of the cell wall to potassium. So potassium can't get out quickly.
Do you get like a spastic paralysis type thing going on? Because they're just, oh no, I guess that just wouldn't work.
Well, I actually think you're right. It's going to have an excitatory effect. So it's going to take longer for that curve to come down because the potassium can't get out of the cell. So we're going to be positive inside the cell for longer. And an example of this is there's a form of epilepsy in cats. I don't know if you've heard about the voltage-gated potassium channel epilepsy in cats. They've documented cats having temporal lobe seizures. So really similar to in kids, the juvenile epilepsy that they get in kids that originates in the temporal lobe. So cats have been documented to get an autoimmune disease where their antibodies target the voltage-gated potassium channels and they have seizures. What's a seizure?
Oh, constant firing.
Exactly, yeah. So an excitatory, hyper-excitatory state. So that's one example. Does anyone know what pyrethrins do?
They're also excitatory. There's like a gardening happening right outside my window. I think they have to do with sodium. However, I'm assuming they kind of cause sodium influx.
Yeah. So what they actually do is normally when the sodium channel, when the gradient with the sodium's already kind of come in, the sodium channels get inactivated and the wall becomes really impermeable to sodium. So sodium can't move unless it's told to move. And what the pyrethrins do is actually stop the inactivation. So you get opening of the sodium channels when they should be closed and increased permeability to sodium. And therefore the cell resting potential can creep up and hit threshold potential without there necessarily being a neurotransmitter trigger for that. So we've got clinical relevance for those sodium channels being dysfunctional. We've got a clinical relevance for the potassium channels being or not working properly. We might move on to talk about the other end of the nerve. So at the nerve terminal, and I'm going to draw another picture just for fun. Okay, so we've got this really long axon. Maybe we'll talk about that a little bit first, that terminates in this nerve terminal. So say we've got a horse and it's got to get a signal from its brain to its back foot. What sort of tricks does a nerve have, or what feature does a nerve have which allows that signal to get there really fast, the action potential to work its way along that nerve really, really fast?
Has myelin.
Insulated.
Yes. What with?
Myelin.
Good. Excellent. So what that myelin does is actually decreases the permeability of the wall. And you sort of think, well, then the sodium's not going to be able to get in and then it's not going to transmit as fast as it should. But what it actually does, so any wire or anything that's running electricity through it loses some of the electricity and the energy through its membrane, essentially. And that's called capacitance. So the signal would potentially never get there in a horse or in a really long nerve, a really wide nerve that has big surface area. It's going to lose a lot of its energy. So what that myelin does is insulates the signal, stops the loss of electrical energy through the membrane, and means that you've got a bit of sodium coming in here, and that causes positivity here, 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 and then the sodium starts flowing in here, and that causes positivity, and then it gets to here and more can flow in. So rather than having sodium channels right along the entire nerve, you've got them at these nodes, these gaps between myelin junctions, and that just keeps the signal hopping along, kind of almost skipping, rather than waiting for all of those sodium channels to open. So that's sort of transmission of the action potential. But then once we get down to the nerve terminal, Jeff, you talked about the calcium channels. Do you know what the calcium channels do down this end?
I don't think so, no.
So normally the inside of the cell is negative, and as soon as all that sodium gets down there, it goes positive, and that triggers a calcium channel to open. So voltage gated means dictated by electricity. So positivity inside the cell opens this calcium channel. We get influx of the calcium. And what that actually does is triggers the little vesicles which carry the neurotransmitter in this nerve terminal to make their way down to the synapse. And this is a vesicle fused to the end of the nerve terminal and emptying its contents into that synapse. Does that make sense?
No, I'm just, hang on. You said the inside of, like at the end of the nerve terminal, when it's brought the sodium in, it's positive. Well, how does a calcium come in it's a positive ion itself? How does it come in unless it's actually pulled in?
Yeah. It's down its concentration gradient. So
right.
rather than
electrical gradient.
So those are the two players. Yeah.
Not an electrical gradient.
Exactly. And you're exactly right. If that was a voltage-gated sodium channel and we've already got sodium at equilibrium, it's not going to flow in because it's too positive inside the cell. But it wants to balance both its concentration and also its electricality. So calcium will come in down there. And the specific reason for that is to allow those vesicles to then empty into that synapse. And then what happens in the synapse? So say we're dealing with acetylcholine, so neuromuscular junction. So we've got acetylcholine now in our synapse. What's it going to do?
Stimulate the receptors on the other side of the junction.
Exactly right. Yeah. So it's going to bind to the receptors, and what's that going to do in the muscle?
Stimulates it, but I'm assuming I don't remember what the chemical thing is. Sorry.
No, that's all right. So it opens a few little sodium channels. So it's not necessarily chemical. So this is acetylcholine specifically. Opens some sodium channels, which allows a little bit of sodium to flow in. And then all of the voltage-gated sodium channels detect that change in electricality, and all of them open at once, and you get a flood of sodium into the cell, and calcium in the case of muscle. So neurotransmitters can either cause opening of channels and changes in like trigger and action potential, or they can actually trigger second messenger signaling. Do you know what that means?
It suggests there's another chemical involved.
Yeah, exactly. This is oncologists know the names of all of them. It's definitely not what I'd expect with medicine, but we're getting more and more small molecule inhibitors that we're using clinically. Can anyone think of any examples?
Serotonin.
So that's a neurotransmitter, but a medication that's a small molecule inhibitor that we use in oncology.
Oh, like tyrosine kinase inhibitors?
Yes, very good. So tyrosine kinase is one of those second messengers. So what a second messenger does, in response to a neurotransmitter binding to the receptor, the second messenger then releases something from inside the cell, and that messenger goes into the nucleus and triggers either some sort of protein to be generated, or triggers a change in energy consumption, or triggers something inside the cell, changes the metabolism inside the cell to affect the function. So that might be increasing protein production, or changing its energy, opening more sodium channels, opening more potassium channels. There's absolutely endless functions that they can cause. But for our situation, what we want to understand is, in the nerves, basically, is it excitatory or is it inhibitory? So is it going to increase the activity of the nerve, or is it going to decrease it? So it's a good segue into the different neurotransmitters that we work with. And I have to say, it's something I find very confusing, and I thought I had it really straight in my notes, and now I'm trying to interpret it while we're talking, which is less effective. So can anybody think of an excitatory neurotransmitter? One that's going to increase positivity, stimulation.
Acetylcholine.
Yes, good. Any others?
The only other one I know is serotonin, that I could think of at the moment, but I don't know if it really does. But
what about if we're thinking about like our cardiovascular physiology? What's a chemical which is also a neurotransmitter, which acts locally on the heart and increases heart rate?
Adrenaline or noradrenaline.
Yes, excellent. Yes. So adrenaline is only secreted from the adrenals and into circulation. Noradrenaline is produced locally at the nerve terminals and is one of the neurotransmitters of the sympathetic nervous system. So excitatory neurotransmitter. So with acetylcholine and noradrenaline are predominantly peripheral. Does anyone know what the main central excitatory neurotransmitter is?
Probably adrenaline, is it?
Not adrenaline. Starts with a G.
Yeah, does it say the GABA? The GABA.
No. The other one. There's two with a G. Oh, there's three with a G, actually. Sorry, I'm teaching my daughter to read, so G is now. Gotta go. It's glutamate. Do you remember glutamate?
Oh, yes.
Yes.
I was learning about that with portosystemic shunting and
good hepatic encephalopathy. Exactly. So we're going to cover that in more detail, but I think it's good time to just start that sort of what the different neurotransmitters do and how they impact nerves. So excitatory increases positivity in the cell, makes them more likely to have an action potential. Inhibitory makes the cell more negative and refractory to an action potential being stimulated. So what are the inhibitory neurotransmitters? Serotonin is one of them, Josh.
Dopamine.
Good, Bron. I always think dopamine's kind of the happy chemical, and I always think, oh, positivity, but it's not. It's the opposite. Very unscientific.
I just knew it was missing from the list. That was my rationale.
Yeah.
Don't reveal it.
And Josh, what was the good one that you said that
GABA.
was not? Yeah. So that's the main one centrally, the inhibitory neurotransmitter.
Okay.
So what clinical relevance does GABA have? What medications act on the GABA receptors?
Benzos.
Good. Excellent. So now that we know that inhibitory neurotransmitters make the inside of the cell more negative, and we know that benzodiazepines potentiate the effects of GABA, what ion do you think is affected by the GABA receptor? Like, how would you make the inside of a cell more negative at rest?
Is it
Blocking sodium in
Yeah. Also,
You could.
Could you
That
get rid
would.
of potassium?
You could, yeah, you could, but potassium's already, so sodium's, you could, yeah, but both of them are positive and they're kind of opposite. They're opposing each other. So you move one and the other one's going to move. What goes with sodium usually and is at high concentrations outside of the cell but low inside?
Is it chloride?
Yes, it's chloride. Exactly.
Chloride was in the mix.
Yes, it's
Okay.
just here to confuse us.
Mm.
So most of action potential generation is influx of positive ions and efflux of positive ions to change the electrical gradient. But chloride can actually, if you open the chloride channels, it goes down its concentration gradient into the cell, lowers the resting potential and makes it more refractory to an action potential. So if we go back to that, you've got to imagine it because I got rid of my whiteboard, but the action potential that we drew, that sort of baseline resting potential is lower. So it's got to increase the electrical gradient by sort of 20 to get to its threshold potential and trigger the sodium channels to open.
So it's making it more negative.
It's making it more negative. Exactly. So it's pushing that line down. So there's one other medication that we use all the time in seizures, which potentiates the effects of GABA.
Diazepam, I think,
Valium.
or phenobarb would be the other one.
Phenobarb, both of them potentiate the effects of GABA. So they work different components of the GABA receptor, but they trigger the same effect in increasing the chloride inside the cell. Can anybody think of any other negative ion medication that we use historically with epilepsy a lot?
Is it bromide?
Yes, exactly. So how do you think that might work?
Yeah, I never probably knew that once, but yeah, I guess it decreases the electrical potential.
Resting potential.
Resting potential.
Yeah, exactly right. Good.
Cool.
Yeah. Making some connections.
Yeah, that's awesome.
So it works similarly to sodium, because you often, I can't remember which test it is, will be elevated if there's a lot of bromide around.
Oh, it's chloride. Chloride actually measures sky high when you've got them on bromide.
Ah, right.
Yeah.
Of course, it's negative. Yes.
Yeah,
yes,
exactly.
Yes.
Yeah. So it shouldn't impact sodium movement, except that it makes that gradient higher, and the sodium really wants to get in because it's really negative. So as long as the cell remains impermeable to sodium, it will remain more negative.
Right. Because the bromide gets in.
Bromide gets in. Yeah, exactly. Yeah. Any other neurotransmitters we should talk about?
Nitrate is one. Nitrite, isn't it?
A neurotransmitter? I don't have him on my... do you know what? GABA, glycine, and glutamate are all amino acid neurotransmitters. So theoretically, nitrate would be a component of all of them, I would say.
I'm probably just confusing it with the effect on blood vessels, peripheral blood vessels.
So there's one other thing that I just sort of saw in my notes, which is potentially worth mentioning, but acidosis and alkalosis in all cells of the body will change ion movement and therefore excitation or inhibitory effect of different ions. So if you've got a very acidemic animal, which we see a lot in our tick paralysis patients, which I think is worth talking about, why do we see acidemia in tick paralysis patients?
So just can't compensate respiratory with their breathing to breathe off the carbon dioxide.
Exactly. So we get carbon dioxide excess, and then we get acid accumulation. So acidosis, what effect will that have on mentation?
Trying to think, will increase potassium moving out of cells.
Mm-hmm.
I'm trying, is that the kind of link you're thinking of, or is it like to?
I was actually thinking more like mentation, like are they bright? Are they quiet?
No,
Are they,
Yeah,
quite
depression.
dull.
yes, exactly. So if you think about when you've got a dull brain, what's going on in that brain? Is there likely to be excitatory or inhibitory neurotransmitters dominating?
Inhibitory, you would say.
Exactly. Yeah. So acidosis decreases excitability. So it decreases the potential for neural activity. It decreases the impact of the excitatory neurotransmitters. And alkalemia does the opposite. So it increases excitability. All right.
How does it do that? You've got a surfeit of positive ions in acidosis.
That is such a good question. And I don't actually know.
Well, it's going to reduce the potassium in the cell, isn't it? Is that going to have an effect on it?
It will produce the potassium, which is going to prolong the excitation time, which actually is the opposite to what we're thinking will happen. So I don't actually know what the mechanism is, but my notes say it, so it must be true. But the only other thing, we've got all these neurotransmitters, we've got all these calcium channels, we've got all these proteins and stuff that are really important. It's very distal end of the nerve. How do they get there? They've got to be produced in the nucleus, which is right at the other end.
Do you mean like the action potential going down the? Is that what you mean?
Not the action potential, but so the distal end of the nerve sits all of these vesicles full of neurotransmitter and very kind of high-tech chemicals and proteins have been manufactured right up at the other end of the nerve. How have they ended up in vesicles down the distal neuron in the nerve terminal?
Are they not generated in the nerve terminal?
Mm-mm.
Don't know.
So there's like almost like a railway system in nerves of microtubules. So they carry vesicles and packages full of things that the nerve needs on its way down. So things to produce sodium, potassium, ATPase pumps and proteins and everything it needs to maintain its metabolic function get transported along these microtubules, and they go back the other way as well, which is quite amazing. So the important part about that is not so much, like, obviously it's interesting for me, but what chemo medication disrupts microtubules?
Interesting.
Good.
Accolades.
What is one of the side effects of increasing?
Not from their main ones, I guess. They can have CNS toxicity.
Absolutely. Yeah. So they're neurotoxic. So the reason is that if you disrupt those microtubules, then you're going to decrease metabolic function within those nerves. We once had a dog that got vincristine, and it walked backwards for 2 days only, and then it was fine.
That's awesome.
Yeah.
That's what we should warn every time we give vincristine. You might have a backwards dog for a couple of days.
I'm sure it's not the worst side effect that has happened, neurotoxic side effect. What's the other side effect of vincristine that other medications don't do, associated with its microtubule effect? What do we use it for other than chemo?
Oh, for platelet release.
Right. Why do the platelets get released?
So they,
Yep.
I can't remember the exact thing, but I know that it kind of cuts it off with the megakaryocytes. It cuts off the tubule.
Microtubule.
Yeah.
Yep, exactly. Yep. So it allows the platelets to be released as they're kind of being like packaged off along those microtubule branches. It just kind of cuts off the microtubules and they get released earlier. So there's just another nice little connection, and also any opportunity to talk about platelets, we'll take it. Okay, so that's pretty much all I wanted to cover with neurophys. Is everybody comfortable with all of that?
Yeah, you've explained it very logically and sensibly.
Thanks,
Piece
Jess.
it all together. It's really cool.
Yeah,
Oh, good.
so
Next subject is neuro exam, which is this is such a huge subject, but I think it's just impossible to learn from a book, and it's much easier to learn from watching and doing. But the only thing with neuro exam that I wanted to go over really is the kind of, I guess, categories of things that are important to make sure that you've looked at. So kind of broad categories. Josh, I've kind of done this spiel with you with patients in hospital. What are your kind of broad categories of your neuro exam?
So you're looking at mentation,
Mm-hmm.
posture,
Mm-hmm.
gait,
Mm-hmm.
cranial nerves,
Mm-hmm.
posture and gait, and cranial nerves,
Mm-hmm.
and spinal reflexes,
Good.
nociception,
Mm-hmm.
and I'm trying to think of.
I think you might have clumped two together. Like, I know you've got a number of things that you're supposed to look at in your head, but you've put posture and gait in together. And there's postural reactions as well.
Right, okay.
Which is, I think the posture might have thrown you off. So that's exactly how I divide it. So mentation, first thing. So I usually just sit on the floor in the consult room or next to the cage and just see how responsive the dog is to noises and what's going on around it and things like that. Whether they're ambulatory or not, and if they're non-ambulatory, what's their posture? Even if they are ambulatory, what's their posture? Like, do they have a head tilt? Are they upright? Are they sideways? Are they stiff? Are they flaccid? All of those things. Postural reactions, what are they? What do we usually call them?
Like conscious proprioception?
Exactly, yeah. And why shouldn't we call them conscious proprioception?
I've probably been calling them that for 16 years, so I'm not sure.
Yeah, me too. And I still say it all the time.
Still do.
Yeah, exactly. VPs, yeah, exactly. Yeah. Essentially, it's not necessarily conscious. So, it
could be just balance.
Yes, yeah. So we should be saying postural reactions, but what they are, how do you do those tests? What do you do?
Floor placement.
Mm-hmm.
Hopping.
Yeah, wheel bearing.
Yeah. And what what is important when you're doing floor placement to, what are the two ways, like, so you can have proprioception, you can test the proprioception. Oh, how am I going to word this question? I think Josh knows where I'm going with this. Tell us, Josh.
Talking about how, if they're putting weight on their leg, that's going to stimulate more their like cerebellar kind of reaction.
Yeah.
Tell me if I'm completely off here, but
No.
or if you're lifting them and placing their paw so they're sensing the dorsal aspect of their paw, and that's more noticing that their paw is in the wrong position.
Yeah, exactly right. There's two ways that a dog can replace their paw. One is that they sense that the dorsal aspect of their paw is on the ground. That signal, sensory nerve, goes up their leg to their spinal cord, up the spinal cord to their brain, and then their brain says, turn that over. That motor nerve goes down the spinal cord through their leg and turns their paw over. And that's what we're trying to test for, those pathways, right? The other way that you can make a dog place their foot back is to trigger their vestibular system. So if a dog feels like they're unsupported, then the reaction that's automated at a brainstem level and doesn't require any cortical input and no intact sensory pathways is to put the leg out and catch themselves. So it doesn't matter really if they've got a sense of falling or anything like that. But if you're not supporting their weight really completely and they're not completely kind of suspended by you, then they're going to have triggering of that reaching reflex, and it's going to make your assessment of that sensory pathway and motor pathway and cortical involvement much less accurate. Does that make sense?
Yeah. I've always done that. Now I know why.
Yes, it's really important to support their weight. I find this really interesting. I won't make you all do it while we're on video and being recorded, but do a little experiment where you stand with your eyes closed and you tip slightly to one side until you lose your balance. So like kind of challenge yourself and notice the muscle activation in your leg that's completely unconscious. So it's subcortical. That's your vestibular system. If you tip sideways and your brain feels you tip sideways, it's going to increase extensor tone in the side that you're tipping towards, which is completely out of your control. So it's a really good way of just kind of thinking about dogs, particularly with vestibular disease. What am I going to be expecting in their reactions? Like they're going to have increased extensor tone on the side that they're falling to because their vestibular system's trying to correct it. And just having that kind of picture in your head and experience of having experienced it yourself. Definitely do that later.
And that's how they get the paradoxical vestibular disease, right? When the other side's pushing them over the other way.
Yes, exactly. Yeah, exactly right. We're going to go on to vestibular disease and I'm going to make you describe that in a lot of detail.
Great.
Yeah.
Okay.
Not today, but be warned.
Okay.
But that's exactly right. Yeah. So you can either, when you've got vestibular disease, you can either have dysfunction and one side not working, or you can have, no, wait. Let's go on to vestibular disease another day. Okay, so we've done postural reactions. What about spinal reflexes? What do you test when you're doing spinal reflexes?
Testing the arc from the limbs, anywhere on the limb, up to where it synapses to the spinal cord. So that kind of reflex arc there. And you're also testing the inhibition of kind of upper motor neurons innervating that area as well.
Good, excellent. What about your crossed extensor reflex? What does that tell you about?
Can't quite remember, but my guess would be, I can't really remember. I think, anyone else?
It occurs when there's major damage to the spinal cord above.
Yeah.
So it would mean there's lack of inhibitory
Good.
From above.
And crossing over. So typically it's like what you said, you're assessing that loss of the inhibition from the upper motor neuron input. It's almost exactly the same. So it's inhibition not from coming down the spinal, loss of inhibition not from coming down the spinal cord, but actually crossing the spinal cord at that level. So typically where we have, for example, increased patellar reflex, we will also have acrostic sensor reflex in similar situation. So what tests do you actually do? And this is quite different depending on where you trained and who taught you and things, to test spinal reflexes in the hind limb, pelvic limb.
Oh, just squeeze the toes.
Yeah. What are you trying to elicit?
Sorry?
What are you trying to elicit when you squeeze the toes?
Oh, withdrawal.
Yeah. Good.
And squeeze the lateral and the medial.
Good. Why?
And then percussion on the muscle, the cranial tibial, and percussion over the sciatic nerve at the hip.
Yeah.
I think that's all I can think of offhand.
Yeah. Well, the patellar reflex we kind of mentioned in regards to the upper motor neuron, but I think that's probably between withdrawal and patella. They're the two most reliable kind of pieces of information we can get from the spinal reflexes in a dog. Withdrawal, if you've got a sciatic palsy, will you have a withdrawal?
Probably not.
Probably not. I agree. Yeah. They should they have normal sensation? I already said they should.
Yeah. I'm not sure. Yeah.
So they should be able to feel it, but they can't actually operate their caudal leg muscles when they've got a sciatic palsy. So they can't flex their stifle. What they can do and will do often is flex the hip. So it's really important when you're looking at the withdrawal reflex that you've got hip flexion as well as stifle flexion, because the hip is actually femoral, whereas the stifle's sciatic, and it really helps you with those L6 caudal lesions to know how focal it is. So assessing both joints.
So that's why those old dogs that have like heaps of degenerative spinal lesions, kind of test that their leg's just going to go forward.
Exactly.
Instead.
That is exactly right. Yeah. So that means they're sciatic. They've got focal sciatic pressure. Now that's really common because what spinal segment does the sciatic come out of?
L6-7.
Yeah, L6S1. Where do we see the most common degenerative spinal disease?
Yeah, lumbosacral.
Exactly, particularly in Goldens. Like Goldens a classic dog for this. Or any large breed dog really, but yeah, lumbosacral is a really mobile section of the spine, so often changes spondylosis, so it's not uncommon in older dogs to have that. As you know, you might be looking for a neck lesion, but you'll also have some spinal reflex abnormalities. So that's kind of spinal reflexes. The other ones, like obviously the perineal reflex, cutaneous trunci reflex, helps you localize. They're all things that, depending on what you're looking for, you're going to be doing. Let's talk about gait a little bit, ambulation. I might see if I can share my screen and we'll do a couple of videos. Okay. Are you all with me?
Yes.
Okay, super. I think gait you can't describe in words. You've just got to see it. So what are the 3 types of ataxia?
Well, cerebellar and vestibular.
Yep, cheating, but yeah. What's the other one?
The other would be a spinal, I suppose, judging by the name of the first 2.
Yep. So we call that a proprioceptive ataxia. So just where they don't know where their legs are in space because they don't have that sensory input usually. So let's have a look. Let's talk first about what a cerebellar ataxia might look like. What would you expect?
High stepping gait, like a Tennessee walking horse.
Yep. Excellent. And are they smooth movements?
Like an intention tremor?
Beg your pardon? Sorry, Sam.
Like an intention tremor?
Yes, exactly. So they often have like an oscillatory tremor in the muscles because there's no smoothing of the higher signals coming through. So let's have a look at a cerebellar ataxia. Can you see?
Yeah.
Good. See the tremor, the really oscillatory kind of bouncing? Oh, 2.
Oh, whoa, the party.
It's a whole
The
family.
best
Whoa,
friends.
whoa.
Oh my God, yeah.
Oh, geez.
They are excited. This is quite fun.
Is this a coonhound problem?
Not that I know of, actually.
Having a coonhound cerebellar home.
Yeah.
Jesus.
But you can see the exaggeration of every single movement is just 5 times the kind of range that it should be performed in. So cerebellum's job is to smooth those high signals coming from the brain down the spinal cord. The cerebellum just says, okay, you really don't need to overreact here. Let's just, that's a big signal. Let's dampen that down a little bit and balance it with what's happening on the other side. So that's quite an extreme version. We've got a cerebellar dog in the hospital at the moment. Has Piper gone, Josh, or is she's still there?
Still in, might go today.
Okay, improved or?
Kind of static, I'd say.
Okay, that's good. She's not quite that extreme. That's quite an extreme version of cerebellar ataxia. But it is a really distinctive ataxia. And every time I do this, it goes back to the beginning. So I'll have to find the chapter again. And then I want to look at the vestibular ataxia. So what's happening with a vestibular ataxia?
Balance is affected.
Exactly.
And I guess like the big part of the system is to try and combat gravity. So that can be kind of turned upside down. So they're often kind of falling to one side or trying to stop falling from to one side.
Yeah, absolutely. And what might you see with so normally the limbs won't cross the midline, and we often see that with cerebellar ataxia where they cross over the midline. That's sort of one of the kind of hallmarks. Can happen with proprioceptive ataxia as well, and particularly when they're turning corners, but walking in a straight line, if their limbs are crossing over, it's usually vestibular. So let's have a look at a video of that. We might be frozen. Oh, can you hear me all right?
Yeah.
So it might be the video rather than... Here we go.
Here we go.
Your internet must be playing up a bit.
Oh, there you go.
So what do we notice here? Whoa.
Head
tilt to the right, falling to the right.
Good. Excellent. So we've got increased extensor tone on which side?
Left.
Good.
Yeah, left.
Yep. Yep. So it's pushing him to the right. Excellent. All right. So that's pretty much all I wanted to cover today. Is anybody got any questions?
I didn't quite understand when we were talking about the sciatic nerve issues with lumbosacral disease. Are we looking for postural or spinal reflex things to tell you? Because it's a common thing that I'm going to be seeing all the time. Do you mind just running through that again? Sorry.
Yeah, for sure. So we will get both the postural reactions impacted by sciatic deficiency, but also the withdrawal.
Right.
So
okay.
Postural reaction is not localizing to the sciatic specifically.
Right.
So that could be femoral, could be sciatic, could be upper motor neuron, could be brain potentially. So it helps you when you've got kind of proprioceptive deficits in the hind limbs, but not the forelimbs. It helps you localize at the caudal to the hind limb.
Yeah.
But when it's hind limbs, when it's all the limbs, it doesn't really help you localize at all. And then, say it's the hind limbs but not the forelimbs, it's got to be kind of T2 caudal, but it could still be like it doesn't help you localize any further than that. And that's where the spinal reflexes help you to localize it further. So then you can lie the dog down on their side and you're going to do their withdrawal. And if they're focal lumbosacral junction disease, they're probably going to bring their leg forward, like contract the hip, flex the hip, but not the stifle or hock, because the
during withdrawal.
Exactly. So they should have no sensation.
Oh, so they'll move at the hip and not the stifle, right?
Yes, okay. Exactly. So they have normal sensation.
Okay.
And they have normal hip flexion because the iliopsoas muscle is still working, but the caudal hammies and stuff and gastroc won't work.
Yeah.
Because they're innervated by the motor sciatic. So that just helps you to localize it. This is LS because the femoral nerve comes off a little bit further cranial, L4 to L6. So often is unaffected when you've got lumbosacral disease.
And the patellar reflex isn't going to localize that. Withdrawal, it's more.
So patellar is predominantly femoral. So it's the extension of the stifle is predominantly managed by the femoral nerve.
Okay.
It's not uncommon to get a slightly reduced patellar reflex, but it shouldn't be absent in a focal lumbosacral region. And
I'm always worried about withdrawal, about whether it's a conscious or an unconscious thing. Is that depending on how hard you pinch? Like how do I tell that?
I actually find really hard because it's so dependent on the dog's level of excitation as well. Like, when they're really highly strung, they're like, woo, with their leg when you tickle them really slightly, or toe, like foot sensitive, then they're going to really react. And then you've got other dogs that are like, oh, I love it when you do that. And don't move their leg. So those ones I tend to pinch them quite hard if they're not retracted.
So you're really just toning it for the level of excitation. So minimal stimulus for the really hypersensitive.
Exactly. So essentially with all dogs, I start gentle and I increase to doing a pain response depending on their responsiveness.
If you need to, okay.
Exactly. So if they're still not responding, I'm going to keep pinching until I get a response.
Okay. Thank you.
Yeah. No worries.
That was
all
great.
Right. Lovely to be back.
Good day, everybody.
You too, Ron. Thanks so much.
I can't remember what we're doing next time, but I'll email it out. Sorry. It'll probably be the next chapter of Ninja. All right. See you guys.
Everyone. Have a good weekend. Bye.